So again, a little bit more on that background. I received my PT bachelor's in 1990 from New York University. All right, back then we did have a bachelor's or a master's. My MA is from NYU as well in biomechanics and ergonomics. I think that's like 1996. I was working here. My first job as a physical therapist was at Mount Sinai Medical Center, roughly from 1992 about 1996. Various things, started an ergonomics program, things of that nature. Always had an affinity for occupational health and trying to keep people out of the workers' comp system, basically, because as you know, it can that can be the disabling factor, right? And then I received my clinical doctorate in physical therapy from Temple. I think that was 2006. Don't hold me to that exact date. But it's been a wonderful ride. You know, I'm a certified ergonomist. That's the last two sort of certifications there. And I have an orthopedic clinical specialty and direct a residency program, which is new to physical therapy, maybe 15, 20 years old. Started on the West Coast, year-long program, didactic and clinical practice, trying to get the residents to be able to sit for board certification. You know, we reinvented the wheel, followed sort of the medical model, but a little bit more succinct. So as far as functional capacity evaluation, so what I was going to try to do today was just give you I think a thought process on how an overview of it, but then how you might look at it as a physician when it's sort of appropriate to order this to be done. And I think some of the hurdles that I've had over the years, I have not done, I'll admit, an FCE in quite a few years. I think a bulk of them done here in New York City, down at OIOC on Downing Street, which is part of NYU Langone. You know, if I were to tell you, if you asked me where to refer, that's where I would say to do it. There's a couple other practitioners, one in Astoria and one in Midtown, that also do them. But if I were to default, I would default first to the people down at OIOC. So as you know, it's basically an assessment of a person's overall function as it relates to their job, right? And that's where I think the barrier has always been, or the difficulty has always been for me when I did these evaluations, as involved as they were, as wanting to know, well, what do they have to do at work, you know, and getting a specific sort of analysis of their work was probably always the problem, you know. But this is the proper times, I think, to think about referring a patient to somebody if you want an FCE. So if they have maximum medical improvement, the MMI has been met, and maybe they have a vocational status where you know they're not going to return to their job, but it might be something that you can use to safely return them to another vocation if they are not sort of capable of the past job. If they are returning to work, hopefully maybe setting some restrictions to that, hopefully short-term rather than long-term, and really additional treatment or referral to work hardening. It's very difficult to do work hardening here in New York, as you know, because of the space. I would call it more work conditioning. It doesn't mimic nearly as many as the job tasks. I used to do work hardening up in Rhode Island, and we had probably a 2,000 square foot space where we literally had ladders set up and shoveling set up and wheelbarrows to push and pull. So that's more of a proper multidiscipline approach with psychology, nursing, physician, OT, and PT. That's truly the definition of a work hardening, several hours a day. And then you might use this FCE at the end of that particular work hardening program to determine the person's function and how much improvement they've made. All this information is on New York State's website, as to be specific, all right? Here in New York, for it to be paid by the workers' compensation system, you have to sort of order it, right? And then the bigger hurdle, getting the carrier or the insurance company to agree to it, right? I think the biggest problem is, as far as I remember, and still I think it still holds today, is there is no specific fee connected to that CPT code. So you have to basically, as the FCE, as the PT doing the FCE, you have to negotiate with the carrier your fee to do it. To do this properly, you do have to really, I find, do it over 2 days. Why do you think that would be the case? Do you have any guesses? To see if they react. You know, they have a joint that might not get swollen in that day performing some activities, and they come back and that knee is blown up. They're in no active spasms, say, in the low back the day you treat testing, and the following day they come in with some signs and symptoms that you would want to note that they had reaction to probably say they did meet their limit on, say, lifting the prior day. That's really the idea of doing it over 2 days. It's almost the thought process of, I think, of being fair to the patient. You're going to have to fill out a form specifically. There's your PDF on the New York State site as the evaluator for the FCE. It's really generic if you look at it. It's like any other really workers' comp form with general information at the top, and then you plug in your report at the bottom into the second page.
So we don't have to request authorization, but the carrier might come up with.
You do, like, we would, no, I would tell my office staff, we need to get the carrier, basically the adjusters. Some adjusters would have a clue about this, to be quite honest with you.
Yeah.
I had the luxury of working at an insurance company up in Rhode Island for 2 years that have wore a lot of hats, and it really gave me an insight into that side of the fence, right? And they're human beings just like anybody else. I tell my students all the time, you get on the phone with somebody on the insurance company, don't be angry right off the bat. They just got to work themselves and are trying to make a living, and oftentimes they might not even be aware of this. And then how do they basically adjust for it in the claim, right? Oftentimes they will have to call the nurse case manager on something like this to get some medical insight. So it might take a little time to do that. So
you usually do it pre-authorization because it is an informal pre-authorization, right? Because formally you're not supposed to require it, right? But in practice,
you're probably not going to get paid.
Yeah.
I would.
Yeah, but then who does it? The physical therapist or usually the?
I would say to the entity providing the evaluation that they're going to do it. We wouldn't put that on you. You know, that you gave us the proper paperwork and sent it to the carrier, great, but then we'll take it from there, and I think most would agree with that.
And the FCE4 is the one that you complete, the physical therapist, which is not the physician, the physical therapist.
Exactly. So the guidelines for, you know, doing this, obviously you have to be safe, reliable, valid, and practical. And like I said, 2 to 4 hours a day over 2 days. If it's really done properly, you have all that equipment and more. But as you can see, trying to fit that equipment into a quote-unquote regular physical therapy practice here in Manhattan is pretty much impossible. So when I did them a few years back, I would just sort of have a milk crate to do my lifting analysis and things of that nature. No, I would not be able to analyze shoveling, but I could maybe mimic it, things of that nature, put weights onto the shovel, you know, head, have them basically climb the stairs in our building, things of that nature. You might get climbing of a ramp outdoors here in this hilly area, say up 97th Street or down it, you know, there's a little hill to it there, but it to do it properly, you want to get that person back in the following day. That is a big obstacle here in New York City when I've done them here in the past. So you obviously have to have informed consent by the patient as well. That usually entails telling them that, you know, it's a tricky situation, right? Oftentimes, many of these patients might be have pain sensitization, fear avoidance, in that they're fearful of moving, and that's going to cause further damage. All those things linked to chronic pain, especially in the spinal column, right? So you really have to let them know that these are the criteria that I'm going to stop the testing. And what that often is physiologically, if they hit 85% of their target heart rate, you stop the test there. If their movement pattern is unsafe, aberrant, and things of that nature, you would stop the test. A gray one is them asking to stop the test because of pain, and you might do a re-examination and say certain signs and symptoms of the area that they're reporting pain in. Oftentimes, you, with this population, you probably continue to test after. But before you even after you get consent, you're going to do a full-blown examination, you know, range of motion, get your history, do manual muscle testing, muscle length, any special tests that you would need to possibly, probably rule out any acute or subacute involvement, true sort of pathology, right? And then you're going to do your battery of functional tests. The key here, I think, is those functional questionnaires. Everybody's familiar with like the Oswestry and the Neck Disability Index. They're self-reported sort of 10-question functional questionnaires, as we call them, the patient fills out. So that's their basic report of what they feel their function is. Neck Disability Index was basically developed after the Oswestry, and is very similar. All those functional questionnaires which are coming up take maybe 5 at max 10 minutes to fill out. 10 questions, something like the DASH might be about 23 questions, just asking them about functional ability with certain tasks. When you get, to me, a true objective finding is when what they report is what they can do. Yes?
So, especially is in English, basically you have Spanish, any other language?
Yeah, Oswestry has been translated into upwards of at least 20 languages, I'm pretty sure.
So the filling out the form is the same for all patients of yours, or it differs basically with the educational level?
It probably does differ with the educational level. I couldn't tell you, again, any valid data on that, but sometimes, yes, I'll sit with the patient and fill it out if they find a barrier there. Literally asking them the questions verbally, giving them the answers, and telling them to just pick one. That's often a sort of a flag to me if they can't pick just one of the answers, because that's how you truly have to score it, that it's valid. But yes, all those little things that you need to do to get as much information as possible is definitely something you'll do. And that's really, I think, the key is that if you want, to me, it's a valid test when you get that functional questionnaire level of ability matching their physical performances during the test. Because that's sort of doing a Piles test for lifting. That weight's going to be blinded. They're not going to know the amount of weight they're lifting. So it's an important component. And you might have them do it with, say, that box, and then you might do it with weighted bottles or something to that nature. That again, they might perceive as different weights, and they're not. So there are your functional questionnaires. The Oswestry, like we said, low back pain, neck disability index was developed off of the Oswestry. The LEFES is actually for the lower extremity, obviously, and developed by an insurance company here in the U.S. Most people don't know that. The DASH was developed up in Canada, and that basically covers everything head to toe. Some FCE evaluators will administer 2 for the same body part, so they might do say the DASH or the say a shoulder patient, and then do a SPADI as well, and want to see that the function even lines up with those questionnaires. So what functional tests are you going to have the patient perform? Well, you're going to pick from here based on the job description if you have one. But I'll get into that in a minute or two. So you might have them bag carry and bottle carry, not only lift, but carry across the room. Say if they were a plumber and were required to carry their tools into a work site as a perfect example. Obviously, this is much more appropriate for somebody doing what I call work or labor. What I do, I don't think is work. I've worked in my past, but my present career is not work. It's a pleasure. So anybody who might have to climb, obviously, in utility is something you're going to want to have stairs or ladders to mimic that and see their ability to do so. Like I said, you might have a bag carry and a bottle carry that, again, is blind. They might perceive it as different, but the weights are the same. Pushing and pulling, when we were in Rhode Island, what we did was we would load up a cart and then load up a sled. Obviously, the sled would have a higher coefficient of friction. So 20 pounds on there would take much more force than 20 pounds on the cart. But what we did is measure out the force, push forces for each one. So 60 pounds on the cart might be 20 pounds on the sled. And if they could do 20 pounds on the sled, they should be able to do 60 pounds on the cart. And we literally had a chart to match that effectively. That's when you feel comfortable that it's objective. There are a battery of sort of tests and equipment that is manufactured by certain FCE companies, Valpar and the Minnesota Tools, that was sort of separated when I converted this over to PowerPoint, that will set up people doing things like screwing nuts on bolts and things of that nature. You get your positional tolerance off times by just measuring the time they're sitting, filling out their paperwork, standing at a workstation and doing a simple task, kneeling and squatting and overhead work. Obviously, going to be something you have to, quote unquote, mimic. And like I said, up in Rhode Island, when we had a good 2,000 square foot space, we had workstations set up to both do the FCE as well as the work hardening. So we used the same environments. We had ladders set up, ramps set up, stairs set up, and again, just measuring distances, time tolerance. Could they carry something up that ramp, carry something up the ladder, carry something up the stairs might also be recorded as well. Push-pull, like I said, the idea of a sled versus a cart with wheels would be different, but you can get objective data out of keeping in mind that they can. All right, I apologize, that's not working. Both of those are videos of, and you can, if you'd like to disseminate the PowerPoint, show a lift carry that shows a fine motor task. The videos are somewhat, they're a couple of minutes, but they'll give you a better feel for what a specific test might look like. That gives you an idea of some of the workstations that are pre-manufactured by certain companies. That's Matheson, well-known functional evaluation sort of continuing ed company, and then they sell all the equipment for you to perform it. Not that you have to go to Matheson to get a JMAR hand dynamometer, but they will sell it to you. Let's see where I am. So your lifting analysis really comes down to lifting and lowering. You can do this in a number of ways. You can do it biomechanically versus the NIOSH, but oftentimes during the FCE, you're going to do it physiologically. They really, all the lifting analysis you'll see, I have in here for you an example to show you that I wouldn't worry if you refer to a specific entity, if they do a Matheson or an Eiserhagen or an Ergos or an Ergoscience FCE, because you'll see they're doing the same thing. They're all basically using a Piles lift in the end. So that Piles was developed, I want to say, in the late 80s as a valid test to blinded to basically look at somebody's ability to lift. But that's EPIC, which is Matheson's explanation of their test, and that's their equipment, and that's them explaining things. And there's a different FCE model explaining the same exact thing differently, but there's the Piles, and that's really the idea is you could set one up to do sort of from waist up or waist down. You want to have them complete 4 lifts in 20 seconds safely with safe mechanics, again, in that their heart rate doesn't go above 85% max. Don't go above 60% of body weight either. So it's blinded. You'll start with 5 pounds and incrementally go up 5 pounds for each battery of testing, giving them roughly a minute or two in between lifts to physiologically recover. That's the best and simplest way to get your information on lift tolerance. And that's, again, another film or video of a Piles test. So this is getting at that idea that there are many schools of thought here. I personally prefer Eiserhagen. Why? Because they don't try to sell you things. They basically just educate you on how to use everyday equipment to get this information, where pretty much all the other schools will sell you computer generated data, again, all the equipment to do it and things of that nature. Eiserhagen just basically sells the class. It's actually a husband and wife team out of Minnesota. But you can see there the Ergos has a sort of a electrical dynamometer set up, so instead of physically lifting weight, they get a force of the amount of force they could generate with a lift simulation rather than having them lift the weight. A little variation, but getting really the same information. This is some of the Ergoscience equipment. So you can see it, they're all the same thing in the end. It's just that's adjustable, that you can change the heights, that slide up and down, so you could do the lower or upper extremity Piles test. But Ergoscience is just another company out there. And as you can see, these are all registered and protected names. I prefer Eiserhagen for the reasons I just told you. They're very practical, smart, and have basically performed functional capacity evaluations in the Minnesota region for decades now. So what are we trying to capture, right? If we go back to the Dictionary of Occupational Titles, we're really just trying to capture, is this person functioning at a sedentary, light, medium, heavy sort of overall ability, right? And those are the specific definitions of that. I don't know that a lot of people understand. You guys probably do what truly light duty is defined as. They've turned into a generic term, but it really does mean that the person would be able to lift up to 20 pounds occasionally. So that's a true definition of light duty. So you can see the definitions of the occasional and frequent will go to the frequencies of lifts in an hour and or the total amount of time that they might serve on their overall shift. And it's really, it's at least something to work from, right? I don't know that it's as comprehensive as I would like it to be. When you get, before I've done an FCE, I've always wanted, if I could get it, a functional job analysis. So you basically want somebody going out to the job site and literally measuring the weights objectively. Because when I used to do the work hardening, when I would sit down the injured worker and ask them, you could think of an exterminator up in Rhode Island, and I asked her, well, what's the maximum weight you lift during the day? Oh God, probably about 60 pounds. And then you call the employer, what's the maximum weight they lift? It's nothing, about 20 pounds. And then you go out to the job, and it's about 40 pounds. It's right in the middle of those two perceptions. And that was really, bless you, a constant. So that functional job analysis to me of a third party was the best way to really say to, we used to have the court up in Rhode Island order these things, the judge would order them. And I would feel better if I had that functional job analysis to make the statement to the judge that they could actually return to that job safely or not. Doesn't really exist. I don't know that you're going to get a carrier to agree with it. I just had the Disney version of things up there, and that I was working with the carrier as well. So I had a role literally in the insurance company to help them manage claims. So it was as ideal, I think, a situation as you could perceive. Nonetheless, there was very few Disney versions, as I call it, of claims and things really falling into place like you would want them to fall into it. Anybody familiar with ONET now? ONET. So it's a federally funded Department of Labor sort of website where it describes particular jobs much more at length, not only physical but mental and educational and things of that nature. So if you don't have a functional job analysis, to me, at the very least, the evaluator should be going to ONET, say it's, a construction worker, and get that description and start doing their FCE based on that description. So in that case, obviously, we're probably going to look at as many functional tasks as possible. The lifting, the carrying, the pushing, the pulling, the climbing, all those things would probably be entailed in that constructional work. Whereas,
how long has the ONET been?
That's been around well over a decade. I know that for a fact. It's well over a decade old. It's pretty comprehensive too. It's a few pages long for each sort of job title.
So HR sometimes uses that data to create job descriptions.
That's smart. But as you know, you can have variation from employer to employer. So it's at least something. So that functional job analysis to me is the best way to really do it. I mean, I had a lot of, I considered this fun. I might be a little crazy when I did it, but I got the chance to really see people working for a living. I can remember one afternoon following a garbage truck, literally, and having to measure every so often I can to try to get as much data on it as possible. And that's hard work. Being in a FedEx truck doing deliveries, it really gives you a full understanding of the physicality of those jobs and jobs we take for granted. And there's your link to ONET if you need to. But it really is, I think, pretty comprehensive.
Now, do they have, other, just, like oxygen consumption and other? Yeah. No, right. Yeah, so that's an additional. Yeah, because I know of other sources I have. So, we had a lecture here a few years ago, about that particular topic, and,
Gotcha.
and they haven't merged.
No.
Yeah.
unfortunately.
Yeah.
We're still siloed with all this information.
Yeah,
It's
I know.
amazing. But I think it does, I think if you look at it, it takes I think a lot of effort, funding to probably put those silos together. And then human resistance to it, right? We carve out our territory, unfortunately. So this
From the FCE, do you include at some point, or is supposed to have been done by somebody, like an exercise test, or you know what I mean, just for cardiopulmonary
no, really,
considerations? I mean,
what we often will rely on heart rate. That's the best you can do. I mean, in an ideal world, you probably would like to have something set up in a medical center, maybe in a basement, and have an exercise physiologist or a cardiopulm, say PT, monitoring that stuff.
the other way, I guess, to make it, to obtain it as part of the evaluation.
Definitely.
Free,
Definitely.
FCE.
And
put it in tandem. I mean, it's so that at least for people mid-40s and up, which is the standard more or less.
Yeah.
Where certain cardiopulmonary diseases can have an adverse impact on exercise.
Definitely. And definitely, I think an important piece. And I would, if that were the case, and say, you're thinking some of the 9/11 issues, right? To me, I would simply just order a cardiac, test and let that stand on its own. And I don't know that the carrier is going to jump at paying for that, but to me, if I had a choice of the FCE or that for that particular population, I'd probably pick the cardiac test because it's going to give you a better indication.
And when we started, the average population people presented was mid-40s.
Okay.
So
Yeah.
you get the picture.
Yeah, definitely.
15 years later.
Yeah,
so.
yeah, exactly. They didn't get any younger.
Yeah.
Now, very good point. So all this information is on those ONET analysis of the jobs. And like I said, the resources available to you, that top is the OIOC down on Downing Street. Still to this day, I sat in that conference room taking my classes a couple decades ago. The gentleman, I think the bottom one is on the Upper East Side, and the middle person has a location Astoria, Queens, to do some FCE. But again, they're definitely going to be more specific to task than anything else. Sedentary jobs, do you think this is warranted? Say an FCE.
Sitting tolerance and standing tolerances, maybe?
I mean, what I would do in that case, because I've had that FCE and said to myself, I really don't know what to do with this. To me, that probably is data that you can get from the Oswestry and another functional questionnaire, and that it matches up. I'd feel comfortable making that statement that that's probably their sitting tolerance. Sitting there long enough with the paperwork, and you'll notice when I used to do this, because we used to have literally a separate room they would do it in, and the windows were basically tainted so they couldn't be seen. But our eye, we might have been at the computer, our eye was when they were standing up. And they'd stand up in about 10 minutes. And they'd report that all the time. So to me, that's a little objective. And then, that's a simple fix nowadays with sedentary jobs. It's a sit-stand option, The Varidesk products are a couple $100. I mean, unless the job hates them and they hate the job, to me, that's an ergonomic fix that's pretty simple for sedentary jobs. It's probably the number one, I think, report. You start getting into the upper extremity sort of pathologies, it gets a little bit more difficult, but ergonomically can be solved, especially with the voice recognition, how far it's come now. So those sedentary jobs, I would say, you don't don't bother, because I think you're going to get a blank stare from the evaluator. You know, those medium and heavy jobs involved in labor, firemen, cops, and things of that nature. To me, construction are probably the most important people to think about.
So, Dr. Friedman, you fortunately, okay. I don't know how that is done.
You want to present it?
You present it.
You can change it.
I did.
So he should be able to.
Yeah,
Is there something?
That's still your.
No,
He
he
can
said-
share his.
He says he presented.
Click on, he can share his screen.
Share the screen. When I did go on.
Should open up his screen. He has to click on OK and share his screen.
Yeah, but the corner it says talking and then that's the rose. I don't know if he has to.
Yeah, on the members.
Yeah. I mean, that can be.
Is it my presenter?
Yeah. Why didn't you view the screen? What's that?
It says he left it.
Oh, no, he left. No, I think he was on the phone. No, he's not now. Okay, all right. All right, so I So do you think that, FCEs in general are alive and well? I mean, in general, or, because there was a time when there was a big boom about it, and, and is that something that, is still done widely, and what is your sense about it?
My sense is it is done less now,
Yeah.
definitely. If I get a random email, a phone call once every 6 months to a year,
Mm-hmm.
I'd say that was the maximum in a year.
Mm-hmm.
It would be a good question, I think, for some of the staff down at OIOC.
Mm-hmm.
Obviously, they would have a better pulse, being that that's well, not solely what they do, but occupational health being really their cornerstone. But no, I don't, because I think what happens is people are quite aware of the problems of space and doing it properly in Manhattan.
Mm-hmm.
And
And what about in other parts of the country? Well, it
other
also
parts of
maybe,
the country,
maybe because we have a lot of sedentary, work.
we're a service industry,
Yeah,
right?
service industry.
Take probably a good 80% of the jobs in this city, right? I would probably put them at sedentary.
Mm-hmm.
It's that population that does quote unquote work for a living, right? That we take for granted. They get the beverages to the restaurants and getting our baggage on and off the plane, and it's that population that I think this is warranted. And some of those companies, I know the airlines are definitely have that pulse on a little bit more. When I worked at a practice in Queens for a couple of years, they used to do what they called an FCE, but it was really a post-hiring screening, and they would do it on an isokinetic machine. So it was really about muscle performance, strength performance, to try to screen for prior injury, right? So they might not have the strength around the knee of the opposite limb if they had a prior injury. And you could see that, and then they would appropriately place them and a less laborious position. But they had to do all that, obviously, post-hire for the legal requirements of it. I mean, even when you're doing, to me, the full barrier test, this can be definitely still a challenging thing. So even PTs wanting to do it, I think is somewhat difficult to do it right. It takes a certain, I think, art to it, along with all the science in learning to handle people, and then calling, you know, making the right call, and that somebody might have chronic pain, have sensitization, and they do need a sort of a biopsychosocial approach to their rehab in order to get their function back, but not reduce their quote-unquote pain, right? If they have that central peripheral sensitization. And that, to me, the new pain science has really sort of opened our eyes to that population, and that we have to deal with them very differently. This could flag them, but I also think a good PT could flag them prior to this FCE, if they're up to par on the new science.
So how do you report if there's a mismatch between the subjective and the objective?
You just,
How do you?
yeah,
How is your wording?
your wording is just that, simply that, is that the patient reports this subjectively. Objectively, they were able to perform at this level. It's not my job to judge that, right? There's a judge to judge that. There's a physician to try to make that call, because ultimately you're going to be making that call. And I'm fully aware it's not my call. I just put the information down as objectively as I can. So subjectively reported, objectively they performed at this level during this test, and at this level during this test. And to me, if you read something like that, that's they're trying to say there's sort of maybe some chronic pain going on, some fear avoidance going on. And if I were you, then I would, to me, I don't know how you might handle that chronic pain patient. What I would ask in return, how would you handle that patient? Like, what when they come back in, and maybe if they were flagged that way, what might you say to that patient?
Well, I mean, it's an issue of pain.
Yeah.
You know, it's at least, you know, we are cornered there into something that is subjective, and that we have to accept as subjective and try to manage, if possible, but sometimes, you know, that's where we're cornered. You know, and it would require discussion with, that actually happens to a few cardiac and pulmonary tests.
Sure.
That sometimes have to be recalled. Now, you know, you have to tell me really what happened here.
Yeah.
And see, you know, if we can, is it something that can be addressed medically, or if it is just we are forming into a subjective, you know, I say, but I can show type of situation.
And I think the interesting point now is that we truly know that central sensitization is going on, right? And some of the research shows just a graded rehab program, while it actually will decrease their subjective reported pain as they increase their function. So that might be another thought. If it's a sedentary job, even getting them to PT to work on, say, some cardiovascular conditioning and general strengthening probably will help them. But we would always start that program telling them, I'm not here to reduce your pain directly. I'm here to improve your cardiovascular ability, which is probably going to help your pain. Your strength, which is probably going to help your pain. But that's not going to be my focus. That's a delicate conversation, but one I can have. Yes.
So FC is done in point of time.
Yes.
The question I have is, as the disease progresses, the chronic pain gets under control, people get more functional. There's no real set design for FCE to be reconducted and reevaluated to confirm or to sort of enhance or change the observation that was done earlier on. What's your take on that?
I think it's tough to get any carrier to agree to a second one. It's just, you know, they're, and it's not, I think it's the effort, right? It's that person who's the adjuster, they're not, from my experience of working in the insurance companies, literally in the next desk, they don't feel educated to make that decision. So they're going to defer to the nurse case manager, again, which might take time, and it sort of gets lost in the dust of that management, or goes to a supervisor, and they might, you know, be busy, and it might take a week or two to get back. So it's almost the diligence in getting that true answer. Oftentimes, I don't think the adjuster feels comfortable. I mean, they don't even know, a lot of them don't even know this exists. Those that do, well, more than one, well, how could they even warrant that medically? You and I can see how it's warranted, and it might take some discussion with somebody you think is trained, but they're not. They're not trained in sort of handling these claims as much as you think they might be. That's really what I learned.
50% disability that you're giving early on can change.
Without a doubt. Without a doubt. Yeah. And it would be appropriate to do that second one, as we see, you know, it's medically warranted, right? And in our minds, a no-brainer. But you know how third-party payers are, especially comp carriers, and that's what I think it comes down to, is that the people, it really comes down to where insurance came from. I mean, I teach the business practices course for physical therapy students and fully try to make them aware that insurance didn't come from insuring from medical care. I mean, that medical care is tied to insurance is crazy, actually, when you think about it. Because insurance pays for a loss. Our health is a loss. It doesn't add up, right? It should be a whole separate thing, but nonetheless, in the U.S., that's just how it's sort of come about, right? So I think that's really some of the problem, is that some of these people might come from an auto insurance background, home insurance background, where there's very little medical, hopefully, involvement, and now they're totally, that's the crux of their adjusting the claim. I mean, and I think we need to understand that a little bit too, to help them navigate. I think to be in a vacuum and just sit there and judge, and that's where I learned it, just sitting there. The people that, you know, have children at home and trying to get through the day, just like a lot of us. They're not, quote unquote, bad people. They're not, you know. They might be having a bad day because they've been yelled at for 6 hours on the phone. That's a different situation.
Yeah.
But I always tell my students, start that conversation with a smile, because they've probably been yelled at quite a bit that day.
Do employers sometimes pay for it? Not really.
Now they default to letting the insurance company and the carrier just, why? You know, they're usually, everybody's busy. I mean, I think we forget that. Employers are very rare, unless they're self-insured, right? Here at Sinai, they can make that call. They don't.
But we're not self-insured.
You're not self-insured anymore?
So it's state insurance. So we have state coverage.
Or did that? No, it wasn't.
It's workers' comp is state insurance, governed by an entity which is risk management, not, we pay our premiums to the state.
Interesting.
For patients who maybe were injured years and years ago, have this disability for a long time, with new adaptive technologies coming out, is there a role then to do this on somebody who's maybe been MMI for 10 years or whatnot? Is there a role to now re-examine with new technologies?
Like exoskeleton?
I mean, there's so much.
Yeah. It's a
Even
great
like the
question.
desks are kind of a new thing.
Yeah, it's a great question. Again, to me, when you're saying that, I'm thinking they might have to be retrained to do something within a sedentary sort of position, quote unquote, not position, but job, right? So to me, I don't know that an FCE would be appropriate in that case. A consultation, an ergonomic consultation would be much more appropriate, which is, to me, the reason I got into ergonomics, it was a solution, right? It was a big solution. So to me, that when you're saying that, that's how my mind works, is that's talking with that particular person. These are the things available for you to maybe be able to interact with that PC, right? And use that. The laborious stuff, that's going to be taking, say, the lifts out, which they're doing. I mean, they're doing, and they were doing it decades ago. But more and more, they really are mechanizing this stuff. This is good. That's probably why it's getting more obsolete, is people aren't going to be lifting at work in warehouses. It's going to be robots. It is already robots, and it's going to be more robots. I think that is still in the Times the other day on I want to say the FedEx hub down North Carolina, exactly, new hub, and the whole thing is mechanized. The lifts, nobody lost their jobs though, which was rather interesting. So I thought that was a wonderful story because risk was reduced, but nobody lost jobs. And I think you can see much more of that. The hardest environment will be going forward construction. It's very delicate to change. I mean, they do quite a bit, but it's still, the engineering of the tools has been wonderful to take out risk. But at the end of the day, they're still climbing. They're still crazy. With all due respect, they really are risk-taking people, because I wouldn't get on that beam. And I've done some crazy things in my life, but not that. So it's going to be tough, I think, to take some of that out. It'd be interesting going forward. Somebody will figure it out, but it's a little, I think, further out.
Very good.
Thank you for your time. I appreciate it.
Yes. Yes. So they're still trying to, like, it's still like a work in progress, but basically, like, right now, just pretty much with their